So friends, so today I'll be talking about this journal, CLOVERS trial. So this was published in NEJM in 21st Jan 2023. So it's a very important trial. So although if you read on the face of it, so it is pretty much the knowledge that we are aware of, but we just need to look at all the background work that has happened as to how we look at this particular trial. So the trial is referenced as early restrictive or liberal fluid management for sepsis-induced hypotension. So published on 21st Jan 2023. So the backdrop of this is what we have understood at this point of time in intensive care is too much of fluid, even in the early part, is found to be detrimental. So this is the backdrop against which these trials are being done to see if initial fluid resuscitation should be less and whether it has a bearing on the survival. So the backdrop is there is this meta-analysis which came in 2017, conservative fluid management or de-resuscitation for patients with sepsis. So this we are looking only in patients with sepsis with hypotension. So this was the biggest meta-analysis of 11 randomized controlled trials, 2051 patients. If you see in patients where there was a conservative fluids as compared to liberal, the ventilator free days was increased, which is good, and ICU length of stay was less. So compared to liberal, where conservative fluid group was there or where patients were de-resuscitated to keep them restrictive, had better outcomes as per this meta-analysis. So that was one of the study. So the conclusions they made in this was in patients with sepsis and ARDS, conservative fluid resuscitation or de-resuscitation led to better outcome with increase in ventilator free days and reduced in ICU length of stay. So this is the forest plot of, as you see, the diamond is towards the left, favors conservative. And this is the ICU length of stay. As you see, the P is significant and it favors the conservative fluid resuscitation. So then we need to look at other data, other subgroup analysis that have happened. If you look at this is a vast data, fluid resuscitation in septic stroke. Again, where it shows a positive fluid balance are associated with increased mortality. So in the vast data, in the subgroup analysis of septic shock patients, positive fluid balance at day 4 was found to have direct correlation with increase in the mortality, and the optimal survival happened if at the end of 12 hours, positive fluid balance was around 3 liters or less. So which means to say at the end of 4 days, if you have too much of fluid positive balance, initial resuscitation is fine, but having positive fluid balance, which is extending to 4 days, definitely had a bearing on mortality. Then there was this SOAP investigator. So these are all landmark trials, as you would know. Even this SOAP study, when they did subgroup analysis, they found that positive fluid balance had increase in the 60-day mortality. And early initiation of RRT outcome was found to be better in this septic group. So this was the French group. So this is the some background we have. Then later on, this was a large observation cohort study which came from Germany, 730 ICUs in 84 countries. They looked at 1,808 sepsis patients. So this is mainly observational study. So where they saw that at cumulative fluid balance was similar between survivors, but day 3 fluid balance, if it was negative, was associated with survival as compared to day 3 fluid balance, which if it was positive, it had a correlation with non-survival. So all these studies basically said at the end of day 3 to day 4, it is not good to have too much of positive fluid balance. So what this basically means is initial fluid resuscitation is fine, but we cannot keep on increasing the initial fluid resuscitation. We need to keep a tab on the cumulative amount of fluid, because if the cumulative amount of fluid keeps going up to day 3 to day 4, then it did have a bearing, and this came from vast data, it did come from SOAP study, and it did come from multiple observational studies. So then after this, we started getting these trials. So it was a refresh trial. So restrictive fluid in a pilot randomized controlled trial in Australia, where this was a randomized controlled trial. It's a small study which came from Australia, 99. So they had 50 in restrictive group and 49 in usual group. And as you see, the 90-day mortality was no different between the restrictive and usual care. And the duration of vasopressor usage in restrictive, as you see, statistically, there was no difference between restrictive and the usual care. So basically, it was a neutral study which said either you do restrictive or usual. It did not have any bearing on 90-day mortality or duration of vasopressors. And here, the amount of fluid used in restrictive group is 32 to 39 ml per case. So very small amount. I'll show you how it has unfolded over years. Then came this RIFS trial. This came in 2019, which is restrictive IV fluid trial in severe sepsis and septic shock. This was a randomized pilot study which came from US. So very similar to the REFRESH trial. REFRESH trial came in 18 by Australian. This came in 2019. This was a randomized controlled trial done in 2 hospitals between November 16 to February 2018. Very similar to REFRESH trial, 109 patients. REFRESH trial had 99. So 55 in restrictive group and 54 in the usual group. 30-day mortality, as you see, there's no difference between restrictive and usual. But the duration of mechanical ventilation in this RIFS trial was significantly less where restrictive fluids was used. And when they looked at other outcome variables like new organ failure, serious adverse events, or ICU or hospital length of stay, there was no difference between the restrictive and the usual group. So if you see the REFRESH trial, they used around 32 to 39 ml per kg. Here in restrictive, they used 47.1 ml per kg. And in usual care, the amount of fluid that was totally used was 61.1 ml per kg. So this we need to compare with all the previous trials. So this was found to be 2 to 3 fold less. Even if you take the usual care, it was 2 to 3 folds less than the restrictive fluids used in other landmark studies. Like if you look compared to reverse, there the total amount of fluid that was used was 168 ml per kg. This was from US in 2001. Process trial came in 2014, again from US. Here the restrictive group used 108 to 130 ml per kg. But when you compare how from 2014 to 2019 we have moved is significant reduction even in the usual care. So this is a restrictive care in process where 108 to 130. Here in usual care you are using 61.1 ml. Promise trial, which came in 2015 by UK, 98 ml per kg, and Arise, which came from Australia, used 108 to 109 ml per kg in restrictive. So this is the sort of a transformation that has happened where even in the usual care, currently in the randomized controlled trials, the amount of fluid is much lesser than what has been used in certain landmark trials in 2014 and 15. So this is what you can gather. So then came this CENSER trial. This was published in American Journal of Respiratory and Critical Care, where they looked at early use of norepinephrine in septic shock and randomized trial. So this came from the Thai group, but US authors also were involved. This was a much larger study, 310 patients. They compared early norepinephrine usage was happened in 155. This is important because our CLOVERS trial, which I'll be talking, is similar to this. And standard was 155, where they continued to give fluid until they became non-responsive, and then they started norepinephrine. So the median duration to start norepinephrine was 93. So the time taken to start, which means they started early, norepinephrine, 93 minutes, as opposed to 192, because here in standard they waited until they resuscitated completely. If you see the shock control at 6 hours happened very early, where early norepinephrine was used. Obviously, standard they were giving fluids, so shock control took much longer time and less number of patients had shock control in 6 hours. But when they looked at 28-day mortality, there's no difference between early norepinephrine and standard. But when they looked at side effects, pulmonary edema was more in standard group as compared to early, 27.7 versus 14.4. And even arrhythmias were more in the standard group as compared to. So early norepinephrine here had favorable benefit in early shock control and less side effects of pulmonary edema and arrhythmia. So that was the conclusions they made. So this was published in 2019. Early norepinephrine improves shock control in 6 hours. So to substantiate this, there are 2 meta-analyses that came, which also showed that early norepinephrine had mortality benefit. So this was the most recent CENSER randomized control trial. After this, now we are talking about CLOVERS trial. So this CLOVERS trial, it was a very large sort of a study, 60 hospitals in USA, where they compared restrictive fluid versus liberal fluid. So in the restrictive fluid group, so the norepinephrine was to be started early. They prioritized norepinephrine. In liberal fluid resuscitation, they prioritized fluid over norepinephrine. So vasopressors were prioritized in restrictive, and in liberal, fluids were prioritized. And randomization happened within 4 hours. Once the patient was refractory to fluid resuscitation, up to 3 liters, 1 to 3 liters within 4 hours. If they are refractory, then they were randomized into the trial. Inclusion criteria is patients with sepsis with hypotension were the patients that were included. So the hypothesis that was generated for this study was that the 90-day all-cause mortality will be lower in restrictive fluid resuscitation group. It means in the group where you are restricting fluid, the hypothesis was that mortality will be less as compared to the liberal group. So the secondary outcome was they looked at ventilatory free days, vasopressor free days, RRT free days, which is the standard secondary outcome, ICU free days, and hospital free days. So these are the secondary outcomes. So the backdrop of this is the liberal fluid resuscitation has low quality of evidence, and this is shown by these two studies. And there are at least 3 good observational studies which says a restrictive fluid resuscitation is superior to liberal. So this is one study from Denmark, and this is a FISH study, and this is from the UK study. These 3 studies are observational studies which have shown signals of restrictive fluid resuscitation to be superior to liberal. So whilst this CLOVERS trial came, classic trial came at the same time. So we need to, it is exactly very much similar for the prototype of the CLOVERS trial. So this came from the Scandinavian countries, Nordic countries, restriction of intravenous fluid in ICU patients with septic shock. This is a classic trial group. So here they look compared between restricted fluid and liberal fluid resuscitation. They looked at 90-day mortality, which is exactly what in CLOVERS they did, and there was no difference. So this is a large study, 1,554 patients, 717 restrictive, 784 in standard. As you see, the median amount of fluid received in restrictive was 1,798. In standard, it was more. But 90-day mortality, which is the hypothesis in CLOVERS, where you say restrictive fluid should have less mortality. In classic, it did not show any difference. 90-day mortality, there's no difference. Serious adverse events, there was no difference. And life support free days and hospital free days were similar between restrictive and standard. So classic trial basically said there's no difference. Either you restrict or liberal, there's no difference. So we'll again get back to our CLOVERS trial. So if you see the classic trial had 1,554 and exactly the same prototype of classic. Here they had 1,563 patients. In restrictive, they had 782, standard 781. So the median amount of fluid was less by 2,134 ml in restrictive group as compared to the standard. So which is expected because restrictive was liberal. And vasopressors were initiated early, that was significant. And the duration of vasopressors that was needed was much higher in restrictive because obviously you started early, so the duration also will be higher. So the primary outcome which they looked at is the 90-day mortality. As you see, it was 14% in restrictive and 14.9% in standard. It was not statistically significant. So here you see the mortality is 42.3 and 42.1. So what it indicates is possibly the patient sickness quotient was possibly much lesser in the CLOVERS trial. So if you see here, the mortality was higher. So that is something what one should keep a note. And if you look at all the baseline characteristics between the restrictive fluid group and liberal fluid group, as you see, none of them are significantly different and they're all well matched. But what is interesting to note, which authors do mention in the limitations, is the SOFA score was considered to be much lesser in CLOVERS trial. So the authors do submit in the discussion saying that possibly if the SOFA score was high, we do not know the effect size would have been better or identifiable difference in the effect size could have been made out is what has been submitted by the authors. And another important difference between the CLOVERS trial and the classic, which are a similar prototype, here 93.2% of the patients, 90 to 93, came to emergency. From emergency, they were randomized. But in classic trial, 34% of the sepsis patients came from the wards and 23% came from operating theaters. So the type of patients were distinctly different in the CLOVERS and classic, because you saw the mortality was higher in the classic trial. In CLOVERS, it was much lesser. And the type of patients also were a little different. So that is one thing we need to note. And when we look at the median amount of fluid that was required over 24-hour in restrictive is 1,267, as compared to around half of it was needed in restrictive as compared to the liberal, which was almost double. And the vasopressor administration was definitely more, because restrictive vasopressors were prioritized. As you see, 59% needed vasopressors as compared to 37.2. And early initiation happened in restrictive, obviously, for obvious reason. And duration of vasopressors also obviously was longer in restrictive. And all this, as you see, was statistically significant. And here, these are all the outcome variables which I said. As you see, if you look at the confidence intervals here, none of them are significant with regards to organ support free days, ventilatory support free days, RRT free days, or vasopressor free days. No difference between restrictive and liberal group. And you can see all the confidence interval, none of them are statistically significant. And then you can look at all the new intubation and the initiation of RRT. So as just you can look at the right hand corner, all the confidence interval, if you see, so none of them are significant with any of the outcome variables one has looked into. Even if you look at serious adverse events, there's no difference. So, and they have looked at new onset atrial or ventricular arrhythmias, ARDS onset, and death from any cause at any location. So none of them were statistically different or significantly different between restrictive and liberal. So then they have looked at mortality, stratifying various variables. Here they have stratified age, and they have looked at the mortality, whether there would be any identifiable difference with age. So this is a subgroup stratification between the restrictive and liberal group. As you see, difference in mortality. So when they compared the sex, there was no difference. Age-wise, there's no difference. And any comorbids, they have looked at whether in any subgroup, whether restrictive and liberal had any difference. As you see, just look at the right-hand corner, none of the confidence intervals are significant. So with mortality in subgroup stratification, there is no difference between restrictive. Having said that, authors do submit that one of the limitations is they have not looked at other subgroup analysis, which means here they have looked only at mortality stratifying for different health conditions, but they have not looked at ventilatory free days, ICU length of stay, or vasopressor free days as a subgroup. They have not done subgroup analysis for that. Here they only stratified the mortality sort of a difference in various subgroups. So this is one of the limitations they address. So here they have again looked at whether there was any difference identifiable with different SOFA scores. Again, there was no difference. So basically, they have looked at stratification of various aspects based on comorbids, age, race, SOFA score, and there was no difference in mortality between restrictive or liberal in any of the subgroups. Okay. So the limitations of the study is some of the patients in the restrictive fluid, they found they had given more fluid. And some of the patients in liberal group, they had given less fluid. And as I said, the subgroup analysis for other outcome variables was not. Subgroup analysis was done for mortality. But like for ventilatory free days, vasopressor free days, length of stays, there was no subgroup analysis or stratification done as it was done for mortality. And the study was unblinded, which means the investigators, when they were assigning to the different groups, restrictive or liberal, so they were not blinded. So there could have a potential bias that could have been infused. And the another limitations is the protocol duration was only 24 hours. So only 24 hours was the time when they had to do liberal and conservative. So we do not know, had we extended this period, whether it had any bearing. And the targets they had in both restrictive were very similar in a heterogeneous population, that is considered as a limitation. And very surprising thing about this study is when they were giving fluid resuscitations in liberal and restrictive, they did not use any advanced hemodynamic tools to assess fluid responsiveness, which means ordinarily in this day and age, we use echo at least as a, they did not use echocardiogram, they did not use any advanced hemodynamic tools to assess fluid response. They used only clinical parameters. So this is considered important limitations, which was not the case in classic trial. And again, as I said, SOFA was much lesser compared to classic trial. So possibly greater effect could have been appreciated were the patients more sicker on the outcome. So this is another limitation. So these are some of the limitations of this study. So the conclusions of CLOVERS trial is restricted fluid resuscitation had no significant bearing on reducing the 90-day mortality. So, and one can look at it as, did we really, so basically you can say either you give restricted or liberal, it did not have any bearing on mortality. But the reason why we mentioned about all the previous trials is we need to see whether are we really doing restrictive or liberal, or it is something that is acceptable compared to all the previous studies, the type of fluids they used. If you look at 2021 guideline recommendation, 30 ml per kg is still recommended in septic shock within 3 hours of resuscitations. And this has a weak and low quality sort of a recommendation. And mean arterial pressure, the recommendation in 2021 is septic shock, vasopressors has to be used to maintain MAP more than 65 if they're not responsive to fluids. This has a moderate sort of a strength and quality of evidence. So now summarizing this, how we look at this CLOVERS trial, our journey so far with regards to fluids, just to reflect on how we have progressed from last 20 years. For 60 kg individual, if you take, reverse, they used 168 ml per kg, which means it amounts to 10 liters of fluids. Then in process trial, which came in 2014, which debunked the early goal-directed therapy, they used 130 ml per kg in restrictive, which is 7,800 ml they used. And in ARISE trial, which came from Australia in 2014, they used 109 ml per kg. This is all restrictive groups where they use 6,480. In PROMISE, the number came down further to 98 ml per kg, which is 5,880. Then came the RIPS trial from US, which used 47. So you can see how over 20 years, we are slowly reducing the amount of fluid that we are giving, and we are calling it as restrictive. So this is a paradox that one needs to appreciate. We are calling it restrictive and we are constantly reducing the fluids. And then came the refresh trial, which is extremes, where they use only 32 ml per kg, which amounts to 1,920 in restrictive. And classic trial, which came from Nordic in 2022, 1,798 ml. So now CLOVERS trial, which we are talking about, the restrictive group at 1,267 ml and liberal is 3,000. So what you are calling liberal here is in fact restrictive from the PROMISE. From 2015, what you are calling restrictive is liberal here. So this is the paradox which I want all trainees to appreciate, how we are adopting more and more less fluids as a norm, and we are trying to segregate and differentiate within that less fluid as liberal and restrictive. So this is a sort of a dichotomous situation that one needs to appreciate, how in last 20 years we are going more and more restrictive, and what is considered liberal in CLOVERS trial was in fact restrictive in PROMISE trial, and thereafter in RIPS trial it was so what we is liberal is considered is restrictive in RIPS. So this is something how we have progressed with fluids. So there is more alignment towards adopting early vasopressors and trying to use less fluids. And we clearly understand there are multiple studies which are really showing strong signals towards not having huge cumulative positive balance at the end of 4 days. At 4 days, one needs to have some sort of a net neutrality or negative balance. So in a zeal to achieve that, even initial resuscitation fluid should be restrictive. So CLOVERS trial possibly will again put a question mark on early sepsis, so surviving sepsis guidelines, which still says 30 ml per kg. Because if you talk about 30 ml per kg upfront, you are giving 1800 ml. So having said all this, please bear in mind, this is not an absolute value because all these trials before this number you are seeing, they would have given 1 to 2 liters as a resuscitative fluid, and after that, these patients would have been randomized. So you possibly have to add 1 to 2 liters to these as restrictive or liberal to make sense of it. So that's about CLOVERS trial. So thank you one and all. So you can visit my website www.drpradeeprangappa.com to react to this lecture. So thank you one and all.